Good morning, everyone. My name is Reha Rabbani. I am an MS4 at Northeast Ohio Medical University in the class of 2022. And today I would like to present on a clinical scenario that I encountered during my neuro elective in internal medicine. And that was at Summa Health System in Akron, Ohio. So the title of my presentation today is called Guillain-Barre and Miller-Fisher Overlap Syndrome, a masked neurological consequence of COVID-19. I wrote this clinical abstract with the help of Dr. Stephen Vetter, DO, who is an internal medicine resident at Summa Health System, and Dr. Bradley Moore, who is a core faculty of the internal medicine residency at Summa Health in Akron, Ohio. I would just like to give a shout out to them, as well as Dr. Cochran, who is the neurologist that I worked with while I encountered this patient. So, as we all know very well at this point in time, the novel coronavirus that was discovered in December 2019, or first reported, that is, has caused lots of effects all over the world and causing a pandemic to spread across the world as well. So as we know, the COVID virus primarily affects the respiratory epithelium, and there's been growing evidence of its capability to affect other cells, tissues, organs, and systems as well. In particular, the one that I am concerned about is the nervous system. And so over the past 2 years now that COVID has been better researched, we've been looking at different ways that COVID can affect the nervous system. And although to this day they're poorly understood, there are certain postulated mechanisms by which it can cause direct infection and injury to the nervous system. So some of these include immune-related injuries, systemic hypoxia, expression of ACE, which is angiotensin-converting enzyme 2, and then the receptor for COVID-19 that's present in the nervous system may also play a role. So this can ultimately damage the nervous system and then impair its functions. So in regards to how COVID can enter the nervous system specifically, the intranasal infection of COVID-19 can travel directly through the olfactory epithelium and bulb, and then travel through the peripheral neurons into the nervous system. And so therefore, the spread of the virus can transport from the olfactory and trigeminal nerve endings into the nasal epithelium and eventually into the nervous system. So when talking about specifically neurological consequences of COVID-19, one of the more recently observed consequences emerging in literature has been Guillain-Barre syndrome. So it's been very well documented in the past that certain viruses such as Zika virus, influenza virus, cytomegalovirus, and Epstein-Barr virus can lead to Guillain-Barre syndrome in patients. And as well, more recently, there's evidence emerging that COVID-19 has been associated with Guillain-Barre syndrome as well. Guillain-Barre syndrome in general is an inflammatory polyradiculopathy that can occur as a delayed outcome due to numerous infections, like we talked about COVID-19 recently. And Miller-Fisher syndrome is a rare variant of Guillain-Barre syndrome, which is characterized by ophthalmoplegia, ataxia, areflexia, elevated CSF proteins, and the presence of autoantibody against ganglioside GQ1B. And GQ1B is abundant in the paranodal region of the nodes of Ranvier in myelinated axons. So there are certain reviews that were published by Caress et al. In 2020 and Aladawi et al. In 2021 that looked at specifically Guillain-Barre syndrome that was associated with COVID-19. And in these reviews, they noticed that a mean age of around 65 years in patients was noted who developed post-COVID Guillain-Barre syndrome. And most of these patients had a mean time of 11 days between COVID-19 and Guillain-Barre syndrome. They noted the clinical presentation and severity of these patients was similar to those who had non-COVID-19 associated Guillain-Barre syndrome. And also in these patients, they noted a demyelinating electrodiagnostic pattern in approximately half of the cases, as well as albuminocytologic dissociation in the CSF in most cases. Very few cases showed positive anti-ganglioside antibodies in the CSF. And in most cases, patients were treated with a single course of IV immunoglobulin, and improvement was observed within 8 weeks. As we know, IV immunoglobulin is the gold standard of treatment when it comes to Guillain-Barre syndrome in general. So the specific pattern that they noticed was that the COVID-19 variant of Guillain-Barre syndrome also usually resolved with the same treatment as the standard Guillain-Barre syndrome, which we all know. And a small percentage of the patients that they noted developed respiratory failure. So in 2021, there was the first ever report published that demonstrated the presence of actual SARS-CoV-19 in the CSF of an adult patient that had Guillain-Barre syndrome. And also as well, this study specifically recognized some cases where COVID-19 and Guillain-Barre syndrome occurred concurrently instead of Guillain-Barre syndrome as a consequence of COVID-19. However, as from my literature search, it seems to be more often than not, Guillain-Barre syndrome happens after the COVID-19 infection has resolved. So there was also a systematic review published by Lee et al. In 2021, which examined cases of Miller-Fisher syndrome, the specific variant of Guillain-Barre. And in their studies, there was a mean onset of time of about 14 or 15 days for Miller-Fisher syndrome associated neurologic symptoms after the diagnosis of COVID-19. And common symptoms in these cases include perioral paresthesias, ataxia, blurred vision, ophthalmoplegia, and generalized areflexia. So they speculated that the neuropathogenesis of this syndrome, like we talked about previously, was via induction of widespread ACE2 expression by SARS-CoV-2 and an overall deregulated immune response by SARS-CoV-2. So when talking about my specific case, I saw this patient in an outpatient setting. He was presenting to us after follow-up of his diagnosis of Guillain-Barre syndrome and after he had already gone through treatment and everything. But I kind of did a chart review to dig into the past course of his symptoms because I thought it was a really interesting case. And since I'm also interested in neurology, it fit quite well with something that I would want to look into to know more about for my future career as well. And so this was a 64-year-old right-handed male. His chief complaint to us was, his chief complaint back when he presented to the hospital was a few days of an aching, throbbing headache behind the left eye with photophobia, phonophobia, pain in the bottom of both of his feet, and a systolic blood pressure of 210. So this was his very initial chief complaint before he had been diagnosed with anything. And as his kind of clinical case evolved when they got to the point of his diagnosis, that occurred much later on. So when he presented with those symptoms, he was discharged after a workup and he developed a new onset left facial droop with numbness and diplopia, as well as numbness and paresthesias in his bilateral arms and legs that began a week prior to his first presentation to the ED, and then altered gait secondary to numbness as well. His numbness ascended to involve both of his hands a day or two later. Some of his notable past medical history included a COVID-19 infection that occurred 1 to 2 weeks prior to his initial presentation. And for this infection, he was treated with 5 days of remdesivir and 10 days of corticosteroids. And he did not need any respiratory support as far as I could tell from his past chart. So his physical exam upon presentation, when he presented with that chief complaint of the aching, throbbing headache and the facial droop afterwards, included difficulty closing his left eye, left mouth and cheek droop specifically, an NIH stroke scale of 4. And then also of note was an upper extremity intention tremor, as well as abnormal coordination as noted on his finger to nose testing, and decreased sensation in his bilateral hands and feet with a stocking and glove distribution. The labs and imaging that were performed showed a CSF analysis of elevated protein levels of 231, elevated red blood cells of 45, and then remaining cytology within normal limits. He had an MRI with and without contrast done of his brain, and that showed enhancement of the meatal segments of the facial nerves bilaterally, as well as the facial ganglion bilaterally, and mastoid segments of the facial nerve bilaterally. So that's noted here in the MRI, both sides. There's enhancement of the facial nerves and facial ganglions, as well as mastoid segments of the facial nerve. So as far as his management and follow-up that occurred at the time of his hospital presentation, he was initially diagnosed with left-sided Bell's palsy and treated with prednisone and acyclovir. However, he showed minimal improvement of his symptoms with that treatment. So later on in his course, he was diagnosed with post-COVID-19 Miller-Fisher variant of Guillain-Barre syndrome. And after this diagnosis occurred, he was then treated with IV immunoglobulin with a dose of 2 grams per kilogram, which is kind of the standard dose, for 5 consecutive days, and then he was discharged home. So at the time of discharge, the patient had weakness in both of his arms and legs, as well as persistent hypoesthesia in a stocking and glove distribution, and he was only able to walk 10 feet with the assistance of a walker at the time. After he was discharged, he went to a skilled nursing facility, and while he was there, he was progressively able to start ambulating with a cane. When he was seen as an outpatient later on, and this is when I saw him at this point in his clinical course, he was improving, but he still had some residual weakness in his proximal arms and legs, as well as lingering numbness in his hands. So when looking at this case, this patient's Guillain-Barre syndrome symptoms fell within the typical time frame of 5 to 10 days post-COVID-19 illness. And important conclusions that can be drawn from this case are the importance of prompt recognition and treatment of post-COVID complications. Although maybe not life-threatening, it is possible that the Guillain-Barre syndrome could have progressed further to lead to respiratory paralysis and failure. So thus, it is very important for us as clinicians to kind of be up to date with the recent literature and studies that are out there in regards to patients, and just take a very detailed history. In this patient's case, his recent COVID-19 illness was very important in regards to his diagnosis. And also, he was initially misdiagnosed. So, of course, when you see a patient with, characteristic symptoms, it's important to think of, I guess, the more obvious diagnoses, but then also with that, kind of consider the more lesser known diagnoses, and then kind of take that whole picture into account and do treatment based off of that. So, like I said, patients are often incompletely diagnosed when they have certain sequelae of COVID-19. So COVID-19 Guillain-Barre syndrome is in particular missed, and recognition of this syndrome is therefore critical for patient care and outcomes. So important for a clinical practice now and from now on, even after the pandemic resolves, is just taking COVID-19 into consideration when it comes to any sort of clinical diagnosis, because as we know, COVID-19 has been known to cause so many different things, all of the long hauler effects that have been seen in recent literature and things like that. Especially the neurological outcomes are pretty, at this point, unknown and still need lots more research and everything. So the reason that I wanted to present this case was to kind of add to the current knowledge about certain sequelae that can occur due to COVID-19, and then in turn lead to more knowledge about it. And then this will hopefully lead to better recognition in future clinicians such as myself, other medical students, doctors, nurses, and all of the medical staff when they see a patient who has this kind of symptoms. And that is all. Thank you so much for your time. I appreciate the opportunity to present on this forum virtually for the ACP. And a huge shout out to everyone at Summa Health who kind of helped me to find out about this conference and then be able to find a patient scenario that I could come up with a clinical vignette and poster for, and then ultimately present here today. Thank you so much.